Good morning, everyone. Today, our last topic for rheumatology is gout and pseudogout. Um, Basically, to talk about gout or pseudogout, collectively they are called as crystal arthritis. Um, so, arthritis simply there is inflammation of the joints, and why they are called as crystal arthritis because they are induced by crystals. And there are two type of crystals. In case of gout there is sodium urate, and in the case of pseudogout there is calcium pyrophosphate. And how they are differentiated, I am going to talk about them in this lecture. First of all, to start with, just to tell you the difference, gout, which is caused by sodium urate or monosodium urate, is more common in males, and pseudogout, which is caused by calcium pyrophosphate, they like this the prevalence is equivalent in the male and females. And mostly it affect like the gout affect the middle-aged males as well as the postmenopausal females, and the onset is acute. And both of them, they are differentiated by how they look, like their shape. Like this one, monosodium urate, they are needle shaped, whereas this one, calcium pyrophosphate, are rhomboid shape. And this one, which is written like uh, fringence or birefringence properties. So, what is this birefringence properties? Basically, they see these crystals under the polarized light, and how they refract the light, we call it as negative birefringence or positive birefringence, right? So, simply negative birefringence is like yellow when parallel to the filter. They use red filter when they see these crystals, and see they appear blue. So they are positive birefringence and they are negative birefringence. So anyhow, the important thing about this thing is like I will show you how they look like, and these are differences which they show on radiology as well as the treatment. So we are going to discuss today crystal arthropathies. Now, crystal arthropathies, as I told you, gout and pseudogout. First of all, we are going to discuss gout. And gout, by definition, is wait, by definition, gout is simply it is a derangement in purine metabolism resulting in hyperuricemia or increased level of uric acid in the blood with monosodium crystal deposits in tissue. So we call these monocrystal crystal tissue deposits in the tissues as tophi, and synovium, in that case it is called as microtophi. So this is by definition what gout is. And simply, if we will talk about the pseudogout, it is again joint inflammation caused by calcium pyrophosphate crystals. Okay, so now we will discuss first of all gout, and then we will discuss pseudogout. The important thing about these conditions are simply uh, okay. Let's discuss gout first of all. So that the things will not mix up for you, because gout we are going to discuss a little in more detail than pseudogout. Gout is common condition, and many of the times the patient present with pain in the first metatarsophalangeal joint. So now there are many causes of hyperuricemia. Simply, uh, uh, again, it is not clear how much you know about the uric acid or purine metabolism, but uh, the level of uric acid can be increased in the blood because it is hyperuricemia in two of the conditions. First of all, either there is production, increased production of uric acid, or the other cause can be due to impaired excretion of uric acid. So when it comes to the increased production of uric acid, now there is there could be many conditions. For example, one thing is called as HGPRT, or hypoxanthine guanine phosphoribosyl transferase deficiency. Again, it's a inborn error of metabolism, in which or you can say it's an inborn error of metabolism, basically, uh, which cause a condition called as Leishman syndrome. So that could be one of the thing. Many of the people, they have G6PD deficiency with glycogen storage disease, um, and sometimes it could be due to some sort of conditions like polycythemia, in which there is increased production of purines, or leukemia, for example, in which there is increased production of purines, or in many carcinomas. Whereas impaired excretion of the urine, in which the urine cannot be thrown out from the body, could be due to renal failure, could be due to drugs like thiazide diuretics or aspirin, could be due to hypertension, could be due to hypothyroidism, and things like this. So, see, either there is impaired excretion and increased production. So, increased production are either cancers or either enzymatic deficiencies, whereas impaired excretion are more common type of conditions like renal failure, drugs, hypertension, hypothyroidism, things like this. So, basically, this G6PD deficiency interferes with renal excretion as well. So G6PD deficiency gives both type of things. Now, what happens is, whenever the patients have gout, what happen is, there is a full, you can say, mechanism behind that. Uh, from where we get the uric acid? Uric acid we can, what you can say, get from the diet. Okay, so for example, meat have a lot of uric acid. We all know this thing, right? So simply purines we get from the diet. Okay, so whenever uh, and uric acid is the final product of purine metabolism. Okay, so simply, whenever we ingest purines, okay, in diet, of course, so the elimination of the uric acid is done by the kidney mostly. Uh, you can say one thing to remember in this way, I'm just telling you the basics just to make you understand the things. 1/3 of urate is excreted by intestines, whereas 2/3 of urate is excreted by kidneys. Okay, like these are the two ways uh, by which urate is thrown out from the body. So the total body have around 1000 milligram of urate. So now what happens is um, simply the uric acid which we get from the diet in the form of purine, uh, or like we take purines in our diet which form uric acid from the diet. Okay, and the uric acid can also be made inside the body by uh, xanthine oxidase. Okay, to show you, maybe we can found something good on the Bing. Okay, just to show you like how this thing work is, um, like this is the cycles, they are showing you over here. Hypoxanthine is converted into uric acid. Okay, so hypoxanthine is converted into xanthine, and xanthine is converted into uric acid. So the enzyme xanthine oxidase is the one which acts over here. So not just this thing, like all, like you will find many cycles, just right, xanthine oxidase thing, and you will found, see, you can see over here the ATP will change into ADP, adenine diphosphate, monophosphate, release inosine and hypoxanthine. So this is the enzyme xanthine oxidase, which will change hypoxanthine to uric acid, right? So now, like this is like the indigenous, you can say, when it is produced inside the body. Okay, so it is the indigenous production of uric acid. And now the uric acid can be taken in the form of purine from the diet, or it can be made indigenously by what I show you, right? So what happens is, when there is impaired excretion of urine, I told you the diseases, renal failure, drugs. And to remember the name of drugs is very, very, very important, guys, because uh, remember, when you will get a patient of gout in the history, you will ask about that drugs. You will ask, like, did you take any diuretics like furosemide, like thiazide? Did you use alcohol, or did you take aspirin? Okay, and also you will ask in the history if they have taken anything which is very high in uric acid, like seafood, like liver, or you can say the organs of the animals, or even the meat. So simply, either there will be increased production or impaired excretion, right? So what will happen, like whatever is the case, um, what happens is, like, the sodium urate crystals are going to um, deposit in the blood, in the joints, in the body. Okay, so what will happen, by the way, in this case is, simply you have to remember, like, when the uric acid level in the body is increased, we call it as hyperuricemia, and they can be deposited in the tissues in the form of tophi, and in the synovium in the form of microtophi, as well as they can be deposited into the bone, and they will crystallize to form monosodium monosodium urate, or monosodium urate crystals. Okay, so monosodium urate crystals that can lead to gout. Okay, now the risk factors for this condition, risk factors I'm talking about gout, are both modifiable and non-modifiable. Simply modifiable, like those which we can modify. Non-modifiable are those like which are, for example, genes or genetics, or like it is more common, gout is more common in males, so being a male. Or modifiable is like those which you can change, for example, alcohol, and taking the diet which is rich in purines like meats or seafood. Okay, so things like this. And there are other risk factors like renal failure and metabolic syndromes, like I told you, um, Leach-Nyhan syndrome. So now what will happen? Like uh, now, um, what is there? The monosodium urate, they are either depositing in different parts of the body, or either they are going to give us a condition, you can say, which will give acute attack of gout. Okay, so simply you can say the clinical features can be divided into um, clinical features can be number one, acute gouty arthritis, or number second, it could be tophi, right? Like this is one of the presentation. And by the way, we also call it as chronic um, tophaceous gout. Okay, so this is like one more name for this condition. So now what happened, guys? Um, what gout gives is acute inflammatory arthritis, right? It gives um, or this condition will give acute inflammatory arthritis. So what will happen that when it gives the acute inflammatory arthritis, the patient will present with severe pain, redness, joint swelling, and usually it is of the lower extremity, and most commonly it is the first metatarsophalangeal joint. Okay, so you can say first metatarsophalangeal joint is the most common one, which is mostly presented. So now this attack, when it comes, it is very painful, and the patient, they present with pain in the foot or pain in the metatarsophalangeal joint, for example, if it is the one which is involved. And the pain is so severe, and the pain can last for several days to weeks, and it may reoccur. I will show you this one. See, you can see over here, this is the first MTB, or first metatarsophalangeal joint. See, this one is inflamed, it is red, it is swollen, and of course, like if you will see the other foot of that patient, so it will be normal. So whenever there is a pair, always compare. So you can compare this foot with the other foot. Some of the photographs for gout is like given for the two foots, like just to tell you the changes. But you can see the inflammation, the redness, the swelling, and of course, like this one is quite tender. Okay, so this is how acute gouty arthritis present. And in the chronic type, what happens is simply the urate crystals can be deposited into multiple areas like cartilages, like tendons, like soft tissues, and like synovium, right? And most commonly, the areas which are involved can be first metatarsophalangeal joint, could be ear, helix, could be around the olecranon. You can say the elbow, bursa. Could be around the tendons or Achilles tendons. So it could be anything, right? And one more thing, the patient may develop gouty nephropathy, or you can say the patient can simply develop uric acid stones. Okay, so when you will study nephrolithiasis, you would understand what I'm saying. You can see over here, I can show you this, see like too much gouty deposit, sodium monourate crystals over here. You can see over here, this is in the ear. And if you will, of course, like see and try to search it, um, just write tophi and you will find like they show you a lot. Most of those pictures are of hands, but or the ears, but simply you can found at other places as well. Like you can write the name of that place, and of course you can see, right? So like this one is around the olecranon or around the elbow. Okay, so simply like these are the tophi deposits. Okay, so now many people they think like hyperuricemia will lead to gout. It's not like this. Like many people they have hyperuricemia, but they never have this condition. Okay, so see guys, what are things are going on. It can lead to acute arthritis. It can lead to tophius gout. It can lead to urinary problems, right? So basically, like this attack, because I've seen patients of this one, how this attack comes on. Usually, you will get a history of someone who have taken too much food with alcohol, and maybe they are taking a diuretic as well. So, see, three things are combining. So, they present to the hospital with pain. Okay, so many of the times, it is not just one joint, rather different joints which are infected. Okay, so this is how they present. By the way, there are mnemonics for this thing. If you want to remember like what to check on the history, simply remember about the drugs you have to ask. Uh, Drugs mnemonic is FACT. So what is FACT? F is for furosemide, A is for aspirin and alcohol, C is for cytotoxic drugs like cyclosporin, and T is for thiazide diuretics. And if you want to know about the foods, which you have to check, the mnemonic is salt. So S is for seafood, A is for alcohol, L is for liver and kidney, and T is for turkey. So remember turkey or meat, right? So see, in the history you will find this precipitating factors. Okay. So remember, guys, hyperuricemia doesn't mean gout, because many people they have hyperuricemia, but they don't have gout. Okay. And also, if someone is presenting with this feature, and you check his uric acid levels in the blood which come back as normal, again you cannot rule out gout in that patient. Okay, I hope you understand. So simply, hyperuricemia doesn't mean gout, and low or normal uric acid levels do not rule out gout. Okay, so this thing is very 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 important to understand. uh, Now guys, about investigations. Okay, what are the investigations that we do? Investigation. So, see, first of all, the clinical picture is quite clear in these patients, how they present. So, quite clear clinical picture can be there. Now, other thing, how these patients present is, um, or what investigations we do in these patients is, um, of course, like you can do a CBC simply as a starting test. Okay, these are baselines. By the way, in this case, okay, I don't want to go like that, but rather I would like to tell you some targeted type of investigations which you will do. So first of all, you can do serum uric acid levels. But okay, this one could mislead you. Why? Because as I told you, that normal or low levels cannot rule out, and high levels doesn't mean like they have gout. Okay, so but we can of course do this test, and of course like renal failure is one of the cause, so you can go for blood, urea, and creatinine. Okay, just simply to check like the renal function test, either the patient have that thing or not. But the targeted investigation for these patients is the joint aspirate. Why we do joint aspirate? To rule out septic arthritis, okay, and to confirm the diagnosis of uh, gout, because you can say greater than 90% of the times you can, or crystals uh, can be seen. Okay. Now the important thing over here. Okay, this one is done. Then I will tell you like how they see the crystals and what. Okay, we can do the X-ray of that involved joint. Okay, sometimes we can do the X-rays to see the tophi, to see the tissue swelling, to see the erosions and things like this. Okay, and of course, like you can do CBC, for example, you can do ESR and CRP. Okay, which are to check for any inflammatory process, right? So now. Okay, I included this one. This one is like how, as I told you, like the monosodium urate crystals, they look like needles. You can see over here, right? So they look like needles. Um, and what they do, like as I told you, they throw a light. Okay, and calcium pyrophosphate, they look like rhomboid shape, which I'm going to discuss in a short time. And you can see over here, like these are needles, right? And these one, they are negatively birefringent, and these one, they are positively birefringent. Like what they do, like they throw a polarized light and they use a red filter and they see like how they reflect the light, and based on that they call it as uh, negatively or positively. So remember, like negatively birefringent are, or needle shaped, is gout or sodium monourate crystals, or rhomboid shape, or positively remember, like P for pseudogout and P for positively charged, right? So they are what you can say, are for pseudogout, calcium pyrophosphate deposition. Okay, so CPPD or calcium pyrophosphate crystals. So needle shape, they are this thing. So this is how they diagnose this condition. Now, to talk about the treatment of this condition, treatment is quite um, um, important in this condition. It's like the patients, uh, they present with too much pain to the hospitals, and of course, like our first target is to control that acute episode. So of course, like when the patient present with acute gouty arthritis, so they are in too much pains. Okay, they are in too much pain, and when they are in too much pain, so the first thing is to reduce that pain, as well as decrease the inflammation. So what drugs you will do use in acute gout? Um, the, the the most important drugs we are going to use is, of course, like NSAIDs. So we give them high dose of NSAIDs. Okay, or you can use corticosteroids. Okay, of course, like intra-articular, intra-articular, like inside that joint, injection, right? So why we use corticosteroids, by the way, that if someone cannot take NSAIDs, because for example, someone have renal failure. See, now why I'm talking about this thing, because see, gout occurs more in renal failure patients. So they cannot take NSAIDs, so of course we will put them on corticosteroids. Okay, now one drug which is mostly associated with gout, and maybe you have heard about that drug before, it is called as colchicine. Now you will read about this drug anywhere, everywhere, like whenever you are going to study gout from any book. So this drug, first of all, have narrow therapeutic index, and this one is drug is only effective when it is given in the first 12 hours. Okay, so the best is to use NSAIDs, and NSAIDs, like if you have done pharma, you know, like there is a lot of NSAIDs, naproxen, diclofenac, you know, Waltrol and all this, like I'm sorry, that is a company name, of course. So indomethacin, of course, like that is the most common one. But nowadays, like, we have a good range of NSAIDs available. Okay, so of course, like, we have to reduce the inflammation, we have to reduce the swelling, we have to reduce the pain. So that is the first thing we do. Okay, but many people who have renal failure, so we give them corticosteroids. Now, this one can be given, but in the first 12 hours, this is effective. And corticosteroids can be given intraarticular, can be given intramuscular, whatever, like, it is decided on time. Okay. Okay, one thing now I'm going to tell you is about a drug which increases the, um, what you can say, increases the excretion of the uric acid from the body. That is called as allopurinol. Now, okay, I don't want you to be in going too much detail, but if anyone wants, like, they can go and read different guidelines or researches. But what I wanted to tell you, that allopurinol basically causes excretion of uric acid from the body. Okay, or you can say this drug is given to uh, treat hyperuricemia simply. Okay, now I am sure, because to be very honest, I don't know the latest um, editions of Davidson or books like this, because what I have is like 2 years or 3 years back. But allopurinol is not recommended to give in the acute attack. Why? Because they say that it worsens the acute attacks. So that's why they say, uh, first of all, treat the acute episode. Treat with NSAID, colchicine, or corticosteroids, and then wait for a few weeks and then start allopurinol. But what I know from my knowledge, allopurinol, like, actually, according to some like latest guidelines, especially like Australian guidelines I've gone through, they say you can start allopurinol right away in the acute attack. Okay, but I don't want to put you in difficulty, so you can say, because in most of the books it is written that it can uh, uh, make the acute episode worse. So don't start it right away. Wait for a few weeks and then start allopurinol. Okay. So this is what is the treatment for acute gout, and then there is chronic gout. Uh, Simply, these are the patients, of course, like, uh, what you can say, who have either multiple attacks. Okay. Um, okay, multiple, like, the first attack maybe is today and the next attack is like maybe next year. Like, there is nothing like this. So what we do, like, we ask them to, first of all, the conservative management, of course, in this one, because in this one there is no conservative management. Why? Because there is no lifestyle modification. The patient is in pain, you have to treat the pain. But the conservative management you can do in these patients is to give them dietary advice. Avoid alcohol. Okay, um, alcohol, and decrease. You can say the high purine diet should be avoided, or you can say avoid high purine diet, right? So this is the dietary advice, you can say, which we give to the patient, right? Uh, by the way, in my country, like, if someone have even infection in nails, so they say, like, can I eat everything? So the thing is that in most of the conditions, like, there is no dietary advice, but in this one, of course, there is a clear cut, uh, you can say, link between the condition. Uh, so this thing, and avoid shellfish, for example. Okay, avoid shellfish. I don't know, like, if the spelling is like correct or not. So sorry for that. So avoid shellfish, um, and spinach, especially. Okay, so all these things are rich in purines. Other than that, avoid the uh, organs, or you can say visceral meat. Visceral meat like liver, kidney, all of them, they are very high in purines. Okay, avoid sardines, very important. Avoid beans, avoid peas. Okay, like these all are high, uh, what you can say, purine contents, and some of the drugs which have hyperuricemic effect. For example, um, pyrazinamide. Okay, so if you know like what is pyrazinamide, okay, and why they use, uh, or ethambutol, these are ATTs or anti-tuberculosis drugs. Thiazide, okay, so thiazides are uh, or have hyperuricemic effect. Okay, so they have hyperuricemic effect. So of course, like avoid them. So this is the advice we give them for chronic gout. And in chronic gout, basically, what is the treatment is drugs like allopurinol, okay, and the drugs like um, fabo, fabuzostat, okay. So basically, they decrease the what you can say uric acid production by inhibiting xanthine oxidase. And there are some drugs. Sorry, yes, maybe I said here, they increase excretion, they decrease the formation. And there are drugs like which we call it as urico uh, uricosuric drugs. Okay, uricosuric drugs. So what these drugs are, they basically um, increase excretion. Okay, so one of the drug which is very important to remember is called as probenecid. Uh, don't get confused. Like maybe most of the books you will just found the name of two drugs like allopurinol and probenecid. Okay, so allopurinol decreases the production and probenecid increases the excretion. So we can give them this drug as well. Okay. Um, so these are the drugs we put them on in these patients, and of course, like if someone have renal disease or renal failure, treat that. Okay. So what are the guidelines to put any patients on these drugs? Is basically the patients who have recurrent attacks. Okay. So or someone who have, for example, tophi or kidney stones. You know, we put them on these drugs. Okay. So chronic gout, of course, uh, they have more of tophis rather than attacks, so that's why we give them these drugs. So this is the thing we are going to give to the patient. So um, remember this thing about what fact I told you about allopurinol. Okay, but and by the way, the patients who are have renal failure, we like they're already taking these drugs, allopurinol. So still, like most of the books says that we cannot give start allopurinol um, during the attack. We have to wait at least 2 to 4 weeks. Okay, some of the book says like you have to wait 4 weeks and then start allopurinol. So what is the function of allopurinol and this drug? Like they block the enzyme xanthine oxidase, and this is an enzyme which is making the, like I show you that photograph, which is converting um, what you can say that hypoxanthine to uric acid, right? So this is the important thing. So um, um, okay, and even this drug is also the same effect. So this is about what you can say the gout, right? And then what is left is pseudogout. So now pseudogout is simply, you can see over here, pseudogout. It is equal in male and female. Okay, and what are the crystals? They are the calcium pyrophosphate crystals. Okay, and this one is mostly monoarticular, and this one P for positive bifringent, P for polyarticular articular. So it mostly affect like many of the joints. Okay, so the good thing about pseudo gout is it takes, yeah, like it starts slowly and it's a self-limited type of condition, and most of the time it is the old age people. It affects the old age people. Okay, and it is also associated with hypothyroidism. You can say diabetes mellitus and things like this. It affects the knees, wrist, could be polyarticular, like it can affect the hips, shoulders, and things like this. And it is quite asymptomatic. Um, you can see either it's acute or insidious, so it is quite asymptomatic. Sometimes, like it is completely asymptomatic, and we just see it on X-ray. And what we see on X-ray, basically, we see the deposits or chondrocalcinosis. You can see, I can show you the X-ray of pseudogout, pseudogout X-ray. Okay, so you can see over here, what we see is um, we can see. Okay, you can see over here. See this line. So this is calcium deposit, or you can see like this line. See calcium. See this one, small whitish area. So this is calcium deposit, right? So this is calcium, like chondrocalcinosis, you can say, which we can see on the X-rays. Okay, no, now this one is mostly asymptomatic and mostly self-limiting. Sometimes, it gives like acute arthritis, and the patients they present with pain. Okay, so now like many of them they have progressive joint degeneration as well, and it can also be triggered by dehydration, acute illness, and things like this. So how we diagnose that thing, guys? Simply the same thing. They can take the aspirate from the joint in, and what they are going to see, they are going to see rhomboid shaped, okay, P for pseudogout and P for positively bifringent rhomboid crystals of calcium pyrophosphate. Okay, and one of the thing I show you is X-rays. X-ray shows chondrocalcinosis. Chondrocalcinosis. So basically, these are the findings which we see around the cartilaginous or in the cartilaginous areas. Okay, and multiple are, see this one, this one, this one, this one, right? So multiple joints, like you will found a lot of um, you can say X-rays. So see, these are, there is lemnisci over here. So see, these are deposited in the cartilages around the knee joint, right? So this is how it present. So now how we treat these patients. Like most of them, they are asymptomatic, but whenever they are symptomatic, we give them NSAIDs or corticosteroids. Okay, so again, corticosteroids can be given intra-articular, corticosteroids can be given orally, corticosteroids can be given, you can say, in the form of injections, right? So this is about um, gout and pseudogout. And rest, guys, I don't think so there is any topic left. And this was the last lecture for internal medicine, and I will see you next time in the exam. Thank you so much for listening.